budget. It's a conversation about forging a truly multiracial democracy where one's opportunities isn't treated as someone else's loss. We see daily how the structural barriers cut lives short. So fixing this means fighting for reparative justice, which means that dismantling bias in our institutions and choosing the right leaders, but also ensuring that our care is culturally safe, not just consistent, but safe. So if we want a future in a state where everybody thrives, we have to make our going to talk about are the strategies, the care practices, as well as the very framework of California health policy and how we embed a conversation like this in it. Because if we're really truly serious about California that works for all, then equality can't be an option. It has to be guaranteed. So with that, we're going to get into it. And so I'm going to start with Kristen, who's going to tell you who she is. But the way our conversation will go is, I know some folks don't necessarily have all of the background on what it means to have a reparations conversation in California and what that conversation was, and how deep it ran. And so, Kristen will give us the outline and the evolution of the task force with Shirley Weber's historical bill when she was still in the legislature, and then talk about how we got where we got. And then we will go to Leslie, who actually puts her hands on folks. So when I talk about the experience of this and the health of people, she'll give us that flavor, as someone who works with birth equity and who's a doula. And then with Senator Dr. Weber Pearson, she'll give us the flavor of her own view legislatively of what's happened, but what will happen. Not necessarily of the caucus or what the legislature is doing, but how she sees the conversation. So with that, how about we start with you, Kristen?
Thank you. Good morning, and good to see so many folks in here that are interested about reparations. I am Kristen Nimmers. I am the Policy and Campaign Manager with the California Black Power Network, and we are a coalition of 44 Black-led, Black-serving organizations throughout the state in many of the major regions where there are a lot of Black folks, including Bay Area, Inland Empire, LA, San Diego, and the Central Valley. And we got to be a part of this reparations work by being an anchor with the Reparations Task Force. So, reparations has been an ongoing multi-generational fight. Ever since slavery ended, folks have been fighting for reparations. And its original iteration was 40 acres and a mule, but as that didn't come and new harms continued to be inflicted upon Black communities, in the 80s, there was a resurgence of the reparations movement. And so one of the representatives in the federal government, Congressman John Myers, introduced H.R. 40, which was a bill to create a federal commission to study the history of slavery, to study the history of systemic racism, and how that led to the current conditions that Black folks are in, and give some specific recommendations on how we repair and redress and address those harms and longstanding issues. And this never really came to fruition. This bill did not pass. In recent years, Representative who recently passed, Representative Sheila Jackson, brought back H.R. 40 and tried to create a federal commission. But now our Secretary of State, Dr. Weber, previously Assemblymember Weber, introduced AB 2131, which was to create a task force at the state level. And this brought together 9 folks, civil rights lawyers, folks who are experts in psychology, folks who who are experts in economics, brought them all together to engage in this 2-year process where they interviewed economic experts, they interviewed housing experts, they talked to community and held community sessions where folks could come in and tell their story of how their families got to America, what was California's role, even though everyone doesn't think of it as a slave state, what was California's role in helping to perpetuate slavery, what was California's role in Jim Crow, and all of these things. And so at the culmination of that 2 years, the task force put out a report. And we worked with the task force as an anchor group to hold community listening sessions. So the task force had like 3 parts of their work where they were kind of doing this research, they were holding community sessions where folks could come in and give public comment, and where they were, publicly interviewing and talking about a lot of the issues. And then they also worked with community-based organizations to hold smaller, more focused group like community sessions where we asked Black folks like, what would it look like for California to be a place where Black people can thrive, and what is it that you all think repair looks like? What is it that we need? And so we held 10 community listening sessions with over 200 participants where we talked about, folks needing mental health access, where we talked about workforce development, where we talked about all of these ways that systemic racism and slavery is still playing a part in the lives of folks today. And so, ultimately all of that work culminated in this final report that they submitted to the legislature, which had in total about 115 recommendations for how the legislature might address systemic racism and help to heal Black communities. And when you break it down, there's really over 300 recommendations, but those are the things that we're now in the current phase of trying to bring to fruition. And those recommendations really ranged across a lot of issues. There were housing recommendations, health recommendations, economic recommendations, because every single facet of Black folks' lives and the current conditions of our community can really have this like line drawn back to slavery. Why are there ghettos? Why are Black folks experiencing, for example, within health, why do Black folks have like the highest rates of asthma? Why is the Black life expectancy rate so low? All of that can be connected to policies that California has implemented and continues to implement that are impacting our folks. And so as a community organization, we are engaging Black voters, trying to get community members more involved in this reparations fight. And then we're also doing policy advocacy and have convened with Equal Justice Society, who is run by Lisa Holder, who's the executive director, but also was a task force member and a civil rights attorney. And we're convening that with her, as well as Dr. Grills and Don Tamaki, who are also previous task force members and are doing a lot of reparations advocacy. So,
thank you. Leslie.
Should I show my presentation?
Yeah, absolutely.
I was mentioning to Dr. Akila that I'm a direct services girl, so I appreciate your grace, and this is not a common space for me, but I'm really happy to be here, and I appreciate your thoughtfulness in being in this space as well. Let's see. I don't know if I can just kind of start. But my name is Leslie. I am I doing this wrong?
Let's see here. X out of that.
Okay.
Yeah. And then
Good to
actually better yet, if you hit escape. And then just go back and start it, because then now it'll recognize the second
one. Well, just to tell you a little bit about myself, I am a midwife. I'm a birth equity lead care manager. I'm a co-founder of Around Birth Collective, and I'm a health ambassador for the California Black Women's Health Project. I support and work with local families in accessing crucial resources and collaborations that center partnership and effective early intervention models. We take care of one another, and that's kind of the sense of my casework. This can look like community outreach events, this can look like home visits, outreach through infant CPR and educating communities and making sure that our folks have the resources that they need to thrive and get quality health and wellness care for Black women and girls. I'm just taking a look at this big number in maternal mortality and infant mortality. We are looking, taking a step back and looking at the California birthing race and ethnicity for communities. Black folks are represented as just 5% in 2021, but that leads me to how such a small segment of the California population can constitute the majority of maternal and infant mortality. So we are seeing this trend again here in infant mortality, and that's more than doubling and tripling in number than the rest of these communities here for Black babies. We're also seeing this trend in low birth weight and preterm birth weights by race and ethnicity, which are heavily affected by social and systemic determinants of health, like Kristen mentioned. Pregnancy-related mortality while pregnant or within 1 year of postpartum. So this can be any cause related to or the management of pregnancy. I don't believe mental health has been considered in this study, and that's trending upwards, and we're looking at possibly 70% of misdiagnosis for maternal health diagnosis. So since 2012, at least 46 California hospitals have shut down or indefinitely suspended labor and delivery services. The number is rapidly growing, and specifically in BIPOC populated communities. And the number rapidly growing is showing an increase in funding towards highly utilized services like the emergency room, which seems a little counterintuitive. And then as a result, large areas of California are without accessing to birthing facilities or maternal safe spaces. So why is this happening? And we just want to make sure folks know that maternal disparities have very little to do with race and more to do with Black women's experience of racism. There's nothing inherently wrong with Black women, and we can't separate maternal mortality and maternal morbidity from inequitable systems that they arise from. So if we're looking at root causes of racism, while social and systemic determinants of health make up the trunk and branches. So if the roots racism, I would say, again, the social determinants and systemic determinants of health are making up these tranches, the trunk and branches. We are seeing an increase in Black birthing families being unhoused, food insecurity, at risk of eviction, depression, interpersonal violence, and difficulties accessing health resources and support. And all of these are interconnected with those things. So environmental, explicit, implicit bias, weathering, allostatic stress and load, allostatic load and stress, and we're also seeing emergencies in hemorrhage and preventable medical emergencies as well during the peripartum time. A Black woman's experience disparities, no matter what their education level, weight, academic, nutrition, income, and then access to prenatal care or early access to prenatal care. So this harm is rooted pretty far back. So looking back at Black women's experience in history and gynecology, the legacy of racial harm in maternal health has very deep roots, and they still exist today in the medicalized system, in schools and trainings, and then pictured here you'll see the quote-unquote father of gynecology, quite a villain, J. Marion Sims, and pictured with Mother Betsy, Lucy, and Anarcha. So mentioning again, California hospitals continue to keep closing their labor wards. We've had several in our counties, San Diego and Riverside County. We're seeing that continue through Los Angeles County. Since 2012, at least 46 have closed and shut down indefinitely. And again, this is a big issue. We have folks crossing zip codes, not getting early intervention, not making prenatal appointments, and the list kind of goes on. So we're really looking at how do we repair this from this lens. And I am no reparations expert, but we have California Black Women's Health Project has begun to look at reparations as a vehicle to decrease and eliminate health disparities. Reparations are not all about cash payments in the way that we're looking at this right now, although we very much believe that cash payments are due. Investments in Black medical institutions, hospitals, evidence-based practices is is justice. Please, and you can screenshot the link to get the full report written by California Reparations Task Force. Also, Dr. Monica McLemore is a premier scholar who beautifully explains the reparations in health field, and I encourage you to look through her work. We also very much believe in a paradigm shift in care for our folks, and we believe in the investment in Black midwifery care. Birth centers and Black midwives will be a key in supporting California's Black birthing families. We have examples of how to fill in the gaps left by hospital closures. Midwives like Maud cared for entire towns, navigated swamps with just a flash to deliver babies in rural areas. Today, Black midwives face similar challenges, but we still boast very positive birthing outcomes amongst clients. Midwives are, in our communities, frequently seen as a key component of perinatal safe spots, providing trusted and focused care model that can be considered comprehensive. A perinatal safe spot is often considered a place where a provider that offers supportive and safe environment for birthing folks. While looking at this great need for safe practice, we can't ignore the history behind rooting out Black midwives and the importance of supporting this workforce, so funding education, programming, professional development for Black birth workers. We also support in research and policy, support for policy, research, and implementation of suggestions from experts and folks with lived experience. AB 55 Bonta with streamlined licensing requirements. This will hope to increase access to maternity care and additional birthing options where it's most needed, centering Black mothers and co-created with Black maternal health leaders across California. And then we absolutely can't forget about the community-based organizations. There's such a, and this is a lot of what I do, it's a big part of care. Not all health is produced within the four walls of the clinic. Actually, evidence is showing that those four walls can be quite harmful to our communities. And perinatal safe spots, it's a must. So the movement for birth equity is also being led with growing momentum by CBOs and focused on caring for Black mothers and advocating for systems change. So we're really thankful for that. And then we also do it for our Black mothers that are no longer with us and for our future Black mothers. I got a little, thank you.
We like that. Senator.
Well, good morning, everyone.
Good morning.
Good morning. All right, there's a lot of people in this room. Want to make sure everyone's awake. And for those of you who are standing in the back, there are seats that are available up here. My name is Senator Dr. Akilah Weber Pearson. I want to start first by thanking you all so much for inviting me to be a part of this panel. I won't speak too long because I want to be able to get to your questions, and I do have a hard stop at 12:15 because I have another panel I have to get to. I kind of serve multiple roles. I am a board certified OBGYN. Am still able to practice on Fridays when I go back to my community. I represent parts of San Diego and parts of East County of San Diego County. I am also the current chair of the California Legislative Black Caucus. And so with the role that I have predominantly as a healthcare provider, I have worked a lot in this space, not only as a healthcare provider or a physician, but also since I've been in the legislature, and specifically focusing on social determinants of health. And I think it's great. I've heard a couple of speakers up here when they're talking about reparations or repairing the past, recognizing that it's not just about a cash payout. There has been so much harm that has been inflicted upon the African American community that giving someone a check is not going to repair the harm that has occurred and has been continuously inflicted upon our communities for hundreds of years. And so we really have to dig very deep with all of the policies and legislation and make sure that we're touching every aspect of society. And that's one of the reasons why coming up here I have focused on social determinants of health. Originally, I was in the Assembly. I started and was chair of the Select Committee on the Social Determinants of Health, because I understand, as many of us do here, which is why you've heard it so much, that 75 to 80% of your health and your health outcome has nothing to do with what happens when you go and see your healthcare provider. That you can go in on your county's health website and type in your zip code, and that will give you your life expectancy, and that should never happen in a state with as much wealth and resources that we have, in a country that has as much wealth and resources that we have. Where you live, where you're born, should not ultimately determine what kind of health conditions you will have, nor how long you will live, and yet that is what we see. I have done a lot of work in the space of improving our implicit bias. Some of you may have known a few years ago, then Senator, but now Supervisor Holly Mitchell, did a bill dealing with implicit bias within our labor and delivery units. Unfortunately, the Attorney General turned around and did a study and found out that people were not complying. That was no surprise to me, because I was there on labor and delivery, and I do not remember getting any kind of training. And I kind of knew when it came out it wasn't going to work just based on how things run. But, followed back up last year with the bill that I co-authored with Assemblymember Wilson to strengthen those requirements and strengthen the consequences if that did not happen. We talked a lot about the labor and delivery units closing, 46 since 2012, but the real horrible fact is that about 27 of those closed within the last 3 years. And so not only do we have an increase, but we have a rapid increase over the last few years. And I'm continuing to have hospitals and hospital systems come and meet with me about their inability to keep their doors open, to keep their labor and delivery units open. And we know that these are critical. Yes, we need to talk about maternal care, how maternal care looks in different communities, ensure that people have access to midwives and doulas. However, at the end of the day, they still need to have access to a hospital. As an OBGYN, I did my residency at Cook County Hospital in Chicago, and those 4 years scared me. I was like, I am never getting pregnant, because it is a very, very dangerous, unpredictable condition. You can think that you are having the most normal pregnancy, and then at the split second, things change. And for Black women, because of racism, because of implicit bias, because of the things that we have endured since the day we were born and all of the impacts that it has had on our bodies, it is very difficult to sometimes realize that our bodies entering in pregnancy are much more weathered and worn down and tired, and therefore we are at increased risk for things like preeclampsia, diabetes, hemorrhage, eclampsia, regardless of our socioeconomic status. And so we need to ensure that even if you have a doula, even if you have a midwife, even if you choose to have a home birth, if something goes awry, you should not have to drive 2 hours to the closest labor and delivery. And unfortunately, that is what we're seeing in some of our hospitals up and down the state. Really tackled a lot with Medi-Cal reimbursement rates. We know that a lot of our patients are on Medi-Cal, and yet for years it has been embarrassingly low, the reimbursement rate for our providers. And so worked a lot on that last year, and with Prop 35, we'll ensure that what the voters have said actually is implemented, so that we can increase the number of providers that will see all patients. But what I tell people is that when we're dealing with healthcare outcomes with our pregnant and birthing people, it is not something that just starts when you become pregnant. It is something that is happening to our bodies from day one. And that's why we have to look throughout entire society. We have to look into our education system. I've done a lot in that space in terms of who's teaching our children, what our children are learning, the disciplinary rates, how African American children are disciplined far harsher than other students. I've dealt with that in my own life. I have 2 boys, and saw discrepancies when my oldest was 3 years old in his preschool that I was paying a lot of money to send him to. And I didn't understand what was going on until I opened my eyes and saw that he was being treated, and he saw it. He told me, "Mom, I like my teacher, but my teacher doesn't like me." These are things that our children are having to deal with at a very young age, and this is having a direct impact on their overall health and health outcomes. Where we live, because of things that happen, such as redlining, where the freeways were put, what communities have the open green spaces to walk and be safe and which ones don't. So when we looked at the COVID pandemic, right, and we said, oh, this community over here is having higher rates of COVID and higher rates of death. But then when you start to peel back the layers, you see, oh, well, this community, they don't have fresh fruits and vegetables. They don't have grocery stores. They don't have the ability to safely walk out and just walk around their neighborhood because of other things that are there, right? We've run freeways through their communities, and so they're exposed to environmental toxins, or they're right next to a Navy shipyard where things are coming in, and these are why they are having such higher rates of medical problems, not because of their genes. It's because of societal factors. And so I'm always telling my colleagues that whatever committee we're on, you have to look at it from an equity lens, but also a health outcome lens, because we will either continue to create communities that are disproportionately healthy and unhealthy, or we can really start closing that gap. But it's not just within the healthcare realm, it's within every single realm that we deal with in society. So with that, I'll stop so we can get to some questions.
Right on. Thank you all for that. So I want to pick up on something that both you and Leslie touched on, which was accountability. Like, how do we hold folks accountability? And as you all know, but I'm not sure everyone does, the report had a number of accountability metrics across systems, but particularly for healthcare systems. And so I want to ask you all a what-if question. So the report and the conversation was really focused on dismantling systemic racism. So what if there was full implementation? Like, and I'm going to just focus on healthcare. If every California hospital, health plan, and clinic were required to meet those accountability metrics that the report calls for and tie it to money. So let's say reimbursement were adjusted for, you had to prove your equity outcomes. You couldn't just say I was doing it in a performative way. Would that spark the change that both of you all are speaking to? Or would it just move the deck chairs around, just shift resources around, because folks would figure out how to game that and do what they need to do? Either one of you.
Yeah, I have some thoughts on that. I think that it would maybe help outcomes, but I don't think that it would completely solve the problem to just have accountability mechanisms for health institutions. And I think a part of that is what some of the conversation was about yesterday in terms of like workforce development and workforce diversity, because part of the bias and the racism that folks are facing is not just related to policies, but related to their interactions with specific doctors. So, you know, a lot of these kind of entrenched stereotypes, for example, around Black women being able to experience higher levels of pain, and those things are also impacting the outcome. So when Black women, you know, say they're having trouble, say they're experiencing pain, say that something is going wrong or something is happening during their pregnancy or during their labor and delivery, they are not often believed. And so we can't just root out racism simply through like changing policies and holding folks accountable to doing anti-bias training, because anti-bias training does not necessarily get at those entrenched beliefs. We also need workforce diversity, and not just like diversity in nurses or diversity in doctors, but also diversity in leadership, who is running the hospitals, who is on the board of the hospitals, who's creating the culture in these health institutions to be able to ensure that they are creating a culture that is more sensitive to and understanding of the historical biases that Black women have faced. A lot of these things are rooted in, like, for example, Leslie talked about, you know, the history and the beginning of gynecology, and this idea that Black folks are less than human, that Black folks are animalistic, and all of that is contributing to these outcomes as well. Like, there are a lot of surveys that have come out where doctors today believe that Black people can experience more pain, where doctors today talk about, for example, this isn't directly related to like maternal health, but in thinking about like dermatology, a lot of dermatology books do not have examples of how different skin conditions would show up on brown skin. And so you may go through education, you could go to school for 7 years and still never see what this skin condition looks like on a Black person. And so when you're actually serving that person, that means that we're having different outcomes. We're not actually understanding how things differently show up in different communities. And also there is like different cultural understandings. I think a lot of folks have probably heard that joke where like a man was in a hospital and he said something about something being the bomb, and they called the police on him because they thought that it was like a threat. And actually it was just a colloquialism that a Black person was using, but there wasn't that cultural understanding. And so folks don't even have the comfortability to be able to talk to their doctors honestly, to be able to share fully what it is that they are experiencing. And a lot of that also has to do with the workforce diversity. So there needs to be pipelines that are also creating leaders in health institutions. And I think often some of those pipelines really are related to how do we get folks in, but not actually see them through the process. Like, are they actually graduating, or did we just get folks into college? And so I feel like, you know, even if we implemented a lot of those measures, there are other deeper systemic things that we still need to adjust for.
Yeah, I agree completely, which is why, you know, when we had the initial implicit bias bill, I said that's nice, but it's not really going to change much, because we have to remember that we all are a product of our society, and that starts, again, from birth. What we are consciously or subconsciously taught, what we consciously or subconsciously see. And so there has to be a shifting of how we move in our society, what our kids are taught about different ethnicities, different racial groups in school, the contributions that different ethnic groups have, who really did what, when, and where. And so that appreciation for others is something that is cultivated. That will take time. And it's great to have those accountability measures, and you must have them, right? And we must have oversight to ensure that that happens. But at the end of the day, you still have to go about a process, which is a much longer process of changing someone's mindset. Increasing diversity in the workplace is a must. We have got to do that. When you were talking about the guy who said the bomb, it reminded me of something that I had seen on social media, where a nurse was talking about the fact that there was a patient after delivery who was like patting her hair like this, and they called like a psych consult because she's patting her hair. But we know that this is because, you know, if you have braids, you know, it's because your hair is itching. And so the nurse who happened to be taking over the shift, and she was like, well, why did she get the consult? Well, she's going like this. And she was like, well, did she have braids? And she was like, yeah. And so it went in, and she was just, you know, scratching. But it's extremely important that we not only increase the workforce, but once that workforce gets there, that they feel comfortable actually being there. I think that, you know, what often happens is, okay, we'll get 1 or 2 Black people to come in, 1 or 2 Black providers to come in, 1 or 2 Black nurses, but the environment itself is still so toxic and so hostile that it's really challenging for those people to stay. And then they're like, well, we hired somebody, but they left, right? But it's because the environment itself had not changed. And so there's a lot that needs to be done. Accountability is one step, but we really have to focus on the societal shift in our mind.
I absolutely echo everybody on this panel, but there is a HEDIS, the HEDIS. It's a standardized set of performance measures used to evaluate the quality of healthcare provided usually by managed care plans and managed care organizations. So I would love to see continued effort in this to hold providers and hold these systems accountable. But looking deeper into that, we absolutely need to look to, what communities are these providers coming from? Are we putting the right folks in place? And when we're talking about funding, we usually see program folks or folks that are implementing be BIPOC folks of color, Black women. I say it's a cycle of Black women taking care of Black women, right? Even sometimes if that comes from a deficit. So I just, making sure that we're actually listening to community needs, not bringing, a doctor from, I don't know, La Jolla going into, El Cajon or similar, comparison. So, again, providing folks safe providers and I also think that when we're looking at the folks that we're up against, we're not looking at folks that fight fair. And we need to include that in our thought process in this paradigm shift. We absolutely need more hospitals. I would love to collaborate further with OBGYNs and create midwifery implementation and collaboration for our communities. So yeah, echoing what everyone else says here, absolutely.
So I want to pick up on this line of it not being enough and really ask, so what is the right bar then? And I ask it in this way. So a lot of folks still use anti-bias and cultural competence, whether it comes to metrics or training or practice or policies and process. And is that still the right bar? Because you even see it in legislation. Or should we be aiming for terms and phrases that, at least in this environment, people are becoming increasingly afraid of? Things like cultural humility, like cultural consistency, or, dare we say, anti-racist practices. Like, how do we measure then shifts in real outcomes if what we're using is not the right way to talk about it?
Well, I wouldn't necessarily say that it's not the right way, but what I'm saying is that it's not necessarily enough. And I think that oftentimes what we'll do as different organizations or even within the healthcare, policy space is we'll focus on our one area. And once we get that done, oh, we got that bill passed, we got this done, we'll pat ourselves on the back and then just step back, right? And even from a legislative standpoint, we have challenges in the past with actually going back and doing oversight and accountability to ensure that what we've said we wanted to happen, what we passed, what we funded actually happened, right? And so we need to do that, but more. And we need to realize we're all here, we're all interested in health, but we have to realize that our voices have to be heard in other spaces too. Your voices should be heard when you're talking about the achievement gap between African Americans and everybody else, right? Your voices should be heard on a local level when when they're talking about planning in your communities and who's going to get what, and if they're going to do electric vehicles or electric buses, which communities get that first, because that ultimately that impacts someone's health outcome. And so what I'm saying is, yes, we have to have that. We have to have the data, we have to have the reports, we have to be able to see, but we cannot just stop there. And unfortunately, oftentimes we do, which is why we don't get the outcome that we ultimately were initially looking for.
Maybe one other thing to think about too is that it isn't just like one single solution, but that this is more of a journey. Like, racism is so entrenched in our systems and our culture that one single policy or one single accountability measure is not going to completely solve the issue. I think one of the most important recommendations that came out of the task force report is for racial impact analysis. So the task force recommended that the legislature continually do racial impact analysis. So if we pass a bill in a year, let's see, how did that actually impact Black folks? Did it create the equity that we were going for? Did it cause new problems? Did it impact a specific sector of Black folks who are impacted differently in a different way? Like, did it impact immigrants differently? Did it impact houseless folks differently? Did everyone have equitable access to whatever it is that this change was? Because it's a continual process. I think maybe sometimes that we are resistant to learning and resistant to continuing to figure out what it is that would work. We think that, okay, if we research enough and we have this one solution, that should be the thing. But I think we are dismantling something and doing something historic that has never been done, and so we need to be more open to learning. I think in academic spaces, they're doing experiments, and this is an experiment. Us dismantling these systems and trying out new things is an experiment. And so I think that this racial impact analysis kind of piece really needs to be integrated into some of this work to continue to analyze how it is that these things are impacting folks.
I have nothing to add. That's well said. Yeah,
Right.
absolutely.
Well, I'm going to ask this one hard question, then I want to see if there are questions in the audience, which is, so there's been a lot of effort and energy, and we're a year away from the report becoming a legislative agenda. And all that conversation about, the change that the task force was going to bring about, and we knew it wasn't going to happen in a year or 2 years, but it was going to start something. And we've also seen, a lot of symbolic reparations. We've seen a lot of symbolic gestures come from the administration. Official apologies and new holidays and things like that. Have the steps that have been taken so far really been transformational in terms of the long journey we need to take and push us in the right direction? Are they real, or are they more performative? And I ask that in, all of you are, in your view, are we at risk of recycling the same legislative priorities and the same policies and approaches without decisive action? Or are we in a moment where we actually, even with what's in the political atmosphere, are we in a moment where we actually see ourselves flipping a switch and doing something different?
Well, I may be biased, but I think that what we have done has definitely been extremely important. It is not performative by any stretch of the imagination. As was just stated, what has happened to us has happened over hundreds of years, and it is not going to change overnight. It is not going to change in 1 year. And, even with the California Reparations Task Force report, I think they even grappled with the fact that there was so much that needed to be done, and that one thing was not more important than the other, which is why they did not list which things should be done first, which things should be done second, which things should be done third. And so, I think what has been done, and there were a lot of things that were done in the reparations space, even before the task force came out. So when we looked at some of the recommendations, we were like, oh, we've already done that, we've already done that, we've already done that. But it's going to be a road. And now with this new administration, it's going to be even more challenging, because things that we may have been able to easily call out in the past as reparations or restorative justice or repairing harm for descendants of American slavery, it's going to be a little bit more challenging to do what we need to do in this current space. But yes, and the current governor has been a great partner in many aspects with many of the things that the California Legislative Black Caucus has done or tried to do. Even, like I said, with him signing, the groundbreaking national bills dealing with lethal force, the the bills that were signed around the Crown Act and Crown Act 2.0. I mean, all of those things, some people may think, oh, that is not significant, but it is significant. It is very significant for me to be able to wear my hair how I choose to wear it, and not have to worry about that. There's enough that I have to worry about when I walk into certain spaces. There's a fine line between being too aggressive and being too quiet. Making sure that my tone is correct, that my clothes are correct, that I'm smiling enough, and now I don't have to worry about my hair. So yes, all of these things have been very important.
And then I would add, maybe I would actually push back on the idea that like the apology is just performative. I think there are 5 specific principles for reparations that the United Nations outlines, and that includes cessation of harm, satisfaction, restitution, compensation, and the apology is a part of satisfaction. We cannot repair harm that we haven't actually acknowledged exists, that we haven't actually acknowledged that California was a part of, and there is a conversation, especially within California and in those purple and red districts around like California wasn't a slave state, we don't owe anybody anything, and we actually do, and this apology acknowledges that. And so I think now that we have the apology, the next phase is, okay, how are we holding the governor, how are we holding the state, how are we holding the legislature accountable to bringing to fruition what you said you apologize for. If you apologize, an apology requires changed behavior. So we need to end harm. We need to actually then continue to make policies that are shifting and changing our culture and changing the way that, you know, we are functioning. And so I'll kind of push back on that being performative, but I also think that, you know, to my point earlier, that this is a journey, like this requires a multi-year strategy. You know, luckily we have some great Black legislators in there, but we only have about 12 of them out of the whole entire legislature. So we have an assembly, we have a Senate, and we need to convince all of those people. There needs to be a multiracial alliance for reparations. There needs to be, you know, new streams of revenue created to fund all of the things that we would like for our communities. We need to be holding corporations, especially those who are connected, their wealth and their, you know, revenues are connected to slavery and to past harms and things like that. So we need to create new streams of revenue. And so I think that there needs to be recognition of the power that we have to build to really accomplish this. If this is a multi-generational fight and folks have been trying to get this done for decades at the federal and the national level across the nation in different localities and different states, I think it's kind of unrealistic to have believed that we were going to pass 300 recommendations from the task force report in a single legislative cycle. And so, you know, this is really a journey, and like everyone has a role in that. And then we just have to recognize that it has to be a multi-year strategy, and it'll require, you know, the accountability, folks in the community and advocates really being a part of and seeing reparations in part of their work. Like, I was really excited that there is a reparations panel at this health conference because y'all are seeing the connection to these historical harms and to health outcomes and to health equity. And that is true for every single issue. I think the senator talked about how folks are often working in their silos, but educational outcomes also impact health outcomes. Whether or not you have housing also impacts health outcomes. And so all of these different sectors, advocates in every sector, need to be coming together to see how reparations touches those work and what is it that we're doing in each of these issue areas in order to kind of bring that fully to fruition.
Mm-hmm.
Absolutely. And this is a super understandable concern here. How does one prove that they're not racist or perpetuating harm in racist systems when white supremacy is everywhere and it shows up differently? I think we have a lot of work to do as far as maternal health. We've been seeing this crisis for over 25 years. It's not getting better, but we are in the work. I know amazing programs and folks that have uplifted community voices, that are active in communities, and you know, we wouldn't have these outcomes without some of this change. I have a caseload of about 75 Black and Indigenous families, and like, I wouldn't be able to serve my folks so directly and in that way without the birthing pathways through Medicaid and Medi-Cal. So I do believe change is coming, and
That's
it's not all performative, but we still have, especially with the current administration as mentioned, we have a lot of work to do.
Yeah. So I'm going to apologize to you all. I lied about letting you all ask questions. So I won't stand between you all and lunch. But I will ask, just in 1 minute of all three of you, if there's the one kind of action you would ask folks to take
coming out of this? If you heard one thing and you needed to do one thing, what would it be you'd ask folks to do?
Create outlets for resident leadership. I am a big believer in that, right? Anything that is about us, we should be included in. So uplifting community voices, bringing folks to your tables, and making sure that it's not just implementation, like let folks see the budget lines and make change, because they can do that.
Right on.
Absolutely. I would say get connected to the folks that are doing this reparations work. You all are important to that fight, especially if you are not Black, because we need a multiracial alliance. You know, Black folks cannot do this alone. And so, like I said, we're convening a reparations alliance called Alliance for Reparations, Reconciliation, and Truth. You can find us at alliance4.org, and then also the blackpowernetwork.org. So please get connected with us. We're building strong alliances.
And what I would say is, you know, everyone in here is concerned about health outcomes, health equity. Just recognize that if you truly, truly are concerned and want to make significant impacts in that area, your voices are going to have to be heard outside of just health spaces as well.
Right on. Thank you, all three of you. Let's give them a round of applause.